The other thing that we've seen more of, and I guess we've seen a couple of papers before, is this whole notion of that CLL cells are often in many patients made much more rapidly than we thought before. So it's not really the case that this is a slow-growing disease. It's rapidly made and rapidly dying off. Well, what have you made of the studies that you've seen here?
Yeah, I think that's right. One of the sort of real changes in our understanding of the disease over the last few years has been partly driven by the new molecules that we have. And so we have a balance, a seesaw really, of proliferation on one side and cell death or apoptosis on the other. And the cells are growing really quickly and are dying, not as quickly as they should, and therefore they accumulate. And we have ways of measuring that with heavy water experiments. And there's two, I think, key studies this year regarding that. First of all, looking at early stage patients, which of course is 80% of our patients at diagnosis. The patients where the birth rate of the cells is high are more likely to progress. Now we have lots of prognostic markers which predict for that, and how that fits in with the VH mutation and all the other prognostic markers is as yet unclear, but it gives us a really nice handle on the real biology of the disease in the early stage. And also we have a similar experiment looking at that in ibrutinib and how these drugs work and switch off proliferation and stop the cells going back into the lymph nodes and back into the bone marrow.
Sure. For patients who are on watch and wait, clearly often a very stressful time. My own patients fall into two categories: the type that are very grateful they don't need therapy yet, and the type that think we're mad not to be offering treatment for leukemia. You already talked about there are other prognostic markers, but can you see a time when we'll be able to identify reliably those patients that we should be offering early therapy to?
Well, there's two questions in one.
Yes, absolutely.
So we can predict the patients who are likely to progress, but we haven't got any test or series of tests that will say this patient will definitely progress. So it allows our prediction to be improved. But the other way of looking at it is that we've got much more effective therapies now. We are moving to combinations of these small molecules and antibodies, chemotherapy-free, to achieve MRD, eradication of detectable disease. And I have to say that the UK is in the forefront of those trials. Our trials are some of the most progressive in terms of combinations. As we have these more effective therapies, it almost becomes less important to treat people in early stage disease, because once they progress, we have effective, safe therapies that we can use. And my sort of perspective on that is that, if you have stage 80 early stage CLL now, in 3 years' time, the world is going to be a different place, because it's a very different place than it was 3 years ago or even 1 year ago.
So there's a good reason to wait.
To wait, exactly.